So first of all, I'd like to thank the organizers and the chairs for organizing the session and for the invitation to speak. So my name is Lorenzo, and I am a psychiatrist working in Edinburgh. I'm going to speak about the role of clinical data linkage in ascertaining clinical outcomes in people that would otherwise have been lost to follow-up in a longitudinal prospective cohort study. So for those that are not familiar with it, the Scottish Bipolar Family Study was started a number of years ago as a prospective cohort study that wanted to look at the development of mood disorders, mainly depression and bipolar disorder in young people. The study design involved recruiting individuals at high risk for mood disorders, and this was based on having a proximal family history of bipolar disorder. So we had a group of high-risk subjects with a close relative with a well-established diagnosis of bipolar. And this group of high-risk subjects was group matched to a group of healthy controls with no family history of psychiatric disorders. And all the subjects were well at recruitment. All the subjects underwent a screening and then were initially assessed at a recruitment with imaging, genetics, cognitive assessment, behavioral lifestyle measures, and a clinical assessment with a skill diagnostic interview. And then they were followed up every 2 years and a half with ongoing clinical interviews. And I've named the different time points T1 to T4. Now, of course, over time, a number of subjects developed mood disorders while others remained well. One of the challenges of the original study was missing data because the subjects were lost to follow-up or dropped out during the follow-up period. At one point, letters were sent to the patient's GPs to attempt to gather more information about them with some results. And now, a few years after the original study, we tried to use clinical data linkage to gather more information about the participants of the original study. Essentially, we tried to determine whether electronic health records could be helpful for increasing the representativeness of our sample and whether we can extract information helpful to establish a disease outcome for these participants. Clinical data linkage was possible through the CHI number, which is a unique numeric identifier that is allocated to each patient when they register with the Scottish NHS. The participants had previously consented to their clinical data being used in this way. And after navigating quite stringent governance routes, we managed to gain access to a number of databases. In particular, we had a prescription data, which was extracted from the Scottish prescribing information system, which includes essentially individual records of prescribing and dispensing of medications in the community in Scotland since 2009. And this database is regarded as having a high level of completeness, especially for prescription in primary care. However, other prescriptions may not be captured. Essentially, we had information about what medications were prescribed, categorized based on BNF categories, but no information on the indication for the prescriptions. Then we had information on outpatient episodes with essentially information about the specialty that was associated to each episode and the date of the contact, but no kind of access to actual notes. And the inpatient episode database, mental health in general, included the diagnosis associated with each episode and the dates, but again, no other information, so no access to medical notes of any kind. And we use the information included in these databases to determine the completeness of the data and extract information useful to establish a disease outcome. For example, diagnosis on discharge following inpatient psychiatric care and number of subjects prescribed psychotropic drugs. so we found clinical records for over 76% of the original cohort of subjects. And on the left-hand side, you can see a table summarizing the main demographical characteristics of the original cohort of subjects. So we had 278 participants, 123 healthy controls, and 155 high risk. And on the right-hand side, you can see the same variables for subjects with information we retrieved with data linkage. So overall, demographically pretty similar cohorts. Prescription data was widely available for over almost 96% of the subjects that we managed to retrieve information on. 23% of the initial cohort of participants did not appear in any of the databases. And we have assumed that these subjects have remained healthy through the period. However, there's a number of possible reasons behind this. For example, they may not have appeared in these databases because they sought private treatment, or perhaps they moved out of Scotland, or perhaps they just simply did not seek help. And we just don't know. So we assume that these subjects remained healthy. Now, this graph is a visual representation of the completeness of the databases. So there are two graphs, one with the high-risk subjects at the top and the healthy controls at the bottom. On the vertical axis, you can see the time with the various years listed. You can see some horizontal dashed lines at the start of each follow-up period. So T1 to T4, starting from the top and going towards the bottom. Now, all those vertical choral lines that you can see. So each line is a subject and indicates on the horizontal axis with a code. And the vertical choral lines indicates the period that that was covered by the data retrieved through clinical data linkage. So as you can see, for most subjects, we tended to have data that cover most of the study period up to 2019. For most of the subjects, the main information was prescription data, as I said earlier on. Now, by the end of the original study, 196 subjects out of 278 were lost to follow-up. With clinical data linkage, we managed to retrieve information on 64 of these subjects that have been lost to follow-up. And on the right-hand side, you can see the proportion of subjects that we had information on at different time points. And this is based only on the research data. So you can see that by T4, the proportion of subjects that we had information on because they had engaged with the follow-up up to the point had dropped to 29%. As I mentioned earlier, at one point during the study, letters were sent to the participants' GPs to see if we could get some more information about how they were doing. And as you can see, we had some improvement in the proportion of subjects we had information on. However, still, especially at T4, the proportion of subjects with information was still quite low. Now, with clinical data linkage, the proportion of subjects that we had information on markedly increased, and this was statistically significant. Now, of course, I've said so far that, of course, we thanks to clinical data linkage, we had more information about more subjects, but what about representativeness? Well, we have some evidence that subjects that were lost to follow-up probably came from a more disadvantaged background. As an example, so you can see on the left side of the graph, the proportion of subjects we had information on by the end of the original study. This was the black kind of bars, stratified by their educational level. So compulsory, more than compulsory, post-secondary education, and then a number of subjects whose educational level was not known. So by T4, we had information only on 20% of the subjects with compulsory education and 28% of the subjects with more than compulsory education. But with clinical data linkage on the right-hand side, you can see the same proportions go up to more than 68% and 76% respectively. And this, again, this is statistically significant. We have also other kind of markers of coming from a more deprived background that I'm not able to show, such as, for example, trauma history or parental occupational level, but essentially the trend is the same. So thanks to clinical data linkage, we managed to obtain information probably on subjects that came from a more deprived background. In terms of what we learned from prescription data, so 34% of the participants were prescribed psychotropic medication at some point during the study period. And the graph on the right-hand side gives a visual representation of this. So you can see the proportion of subjects that were prescribed psychotropic medication expressed as a percentage. On the vertical axis, you can see the different drug classes, so from top to bottom, antidepressant medications, anxiolytics, antipsychotics, and mood stabilizers. And the black bars represent high-risk subjects, and the green bar controls. And on the left-hand side, you can see the proportion of subjects that completed the studies versus the same proportion in the subjects that were lost to follow-up. And you can see how a significant number of prescriptions were issued to participants that were lost to follow-up, especially for antidepressants. However, the difference in prescription trends between subjects lost to follow-up and subjects that completed the study was not statistically significant. What was significant, however, was the difference between high-risk subjects and controls. And as you can see in the graph, there was a marked difference in prescription trends depending on risk status. Indeed, we found that the relative risk of being prescribed an antidepressant for a subject part of the high-risk group compared to an healthy control was 2.8. And the difference for other classes was non-significant, but there was a similar trend. We use the Bonferroni correction to adjust significance levels, so this is quite strict. May have affected the number of significant analyses that we carried out. In terms of psychiatric admissions, so 8 subjects had admission to inpatient psychiatric care, and all were part of the high-risk group. And 4 of the subjects eventually were diagnosed with bipolar disorder, while 4 with major depression. And these were often really, really severe depressive episodes. We're talking about subjects with psychotic features whose perception of reality was deeply disturbed. So these were people that became really, really ill. This is a table showing the final outcome status determined with the aid of clinical data linkage. So overall, we managed to identify a small number of subjects with eventually developed bipolar disorder. Some 58 subjects who developed at least one episode of depression, and 34 subjects that were prescribed antidepressants, but for whom we didn't have any other indication helpful to establish the specific mental disorder. So although the indication for the antidepressant prescription is not known, so it's not possible to say whether it was for depression or other mental disorders, it's probably reasonable to say that these subjects did develop some kind of psychiatric disorder, because we know from the literature that antidepressant prescriptions in primary care are often appropriate. In this graph, you can see on the vertical axis, the participants that developed some kind of a psychiatric disorder versus those that remained well. And on the horizontal axis, we have percentages. The green bars are the controls and the black bars are the high-risk subjects. So on the left-hand side, you can see that the subjects that completed the studies versus the subjects that were lost to follow-up. And if you look at the bottom 2 bars, those are the people that became ill. So if you compare left and right, you can see that generally more high-risk subjects became ill compared to control subjects. And the subjects that were lost to follow-up included the majority of those that became ill, although the difference between people lost to follow-up and subjects that completed the study was non-significant. So overall, just to sum things up, so clinical data linkage proved in our particular study to be an effective instrument to improve clinical outcome determination in a longitudinal cohort study. And information was retrieved overall on more than 60% of the subjects that have been lost to follow up in the original study. We found it was helpful to increase the representativeness of our sample, especially for adolescents and young adults with mental problems, which are probably underrepresented in research and were likely to drop out along cohort studies. And overall, in our study, subjects with a family history of bipolar disorder were at an increased risk of being prescribed antidepressants and developing psychiatric disorders. And with this, just some acknowledgements. I would like to thank, of course, the participants that took part in the study and all the other collaborators and the funders of the research. Thank you.